Very good morning, rather. It's an absolute pleasure. It's an absolute pleasure to have been invited to speak on this symposium, I must say. So the only difference today, can you hear me? There's a lot of noise there. Do you want me to wait until this drone goes away? Thank you. So spondyloarthritis, as most of my rheumatology colleagues know, that it is close to my heart. Of course, that's what most of my PhD projects were all about. So there's a little twist that we are going to talk today about is we'll be talking about these young kids and their cute little backs. So as I'm the only one talking about juvenile patients, so I'm going to start with the basics, like what the juvenile idiopathic arthritis is. So juvenile idiopathic arthritis, in simple words, is a chronic inflammatory arthritis. Chronic means that the inflammation or the symptoms would need to last for at least 6 weeks. And of course, it appears before the age of 16. It's a heterogeneous disease on its own. And as per the original ILR criteria, there are 7 different substages of the subtypes of juvenile idiopathic arthritis. And one of those ones is juvenile spondyloarthritis. I'm not about others, but I always dislike this classification criteria because it's a very sort of difficult to understand, difficult to know, and it doesn't solve much of the purpose because if you do the ultrasounds in patients with oligoarthritis, most of these patients are going to have some enthesitis, subclinical enthesitis, in other words, so that changes the classification criteria a lot. But the good news is that recently there has been a lot of push that we need to redefine this classification criteria, and very recently we have come up with looking at their adult counterparts. So now we need to think about the main 4 subtypes of juvenile idiopathic arthritis, as I mentioned, purely looking at their adult counterparts. For example, we have systemic GIA, we know about the adult onset adult onset still disease, rheumatoid factor positive GIA, again, just like seropositive rheumatoid arthritis, and of course the spondyloarthritis and so on. If some of those kids, for example, they do not belong to any of those stages, they call them as other GIA disorders. And again, if some of those kids with characteristics, for example, they have been into different categories, they are categorized as undifferentiated juvenile idiopathic arthritis. So when it comes to the kids, the life is a little easier. So we have only 2 subtypes, or the two types of arthritis when it comes to juvenile spondyloarthritis. One is enthesitis-related arthritis, and the other one is juvenile psoriatic arthritis. So these are only 2 subtypes. Again, all different subtypes of spondyloarthritis, for example, the axial, the peripheral, non-radiographic, for example, all these different substages of spondyloarthritis, they do happen in the juvenile stages, but there's a little difference is that when it comes to the juvenile spondyloarthritis, there's a much higher prevalence of undifferentiated spondyloarthritis. So that's why rather than defining into different lot of substages or the subtypes rather, they simply look into enthesitis-related arthritis and psoriatic arthritis, which of course make the big group of juvenile spondyloarthritis. This particular slide represents, for example, the frequency of enthesitis-related arthritis and psoriatic arthritis in the overall GIA subgroup. What you're seeing is these are different 8, for example, the geographic regions in the world. So what you're seeing is that there's a lot of difference as regards the prevalence of ERA and psoriatic arthritis in the different geographic countries. But the major difference what you're seeing here is, for example, in the Southeast Asia, there's a much higher prevalence of enthesitis-related arthritis than psoriatic arthritis, 39%. So in other words, the GIA population in the Southeast Asia, 39% of them belongs to ERA. So it means there's a much higher prevalence in our Asian population of ERA compared to psoriatic arthritis. When we look at the prevalence studies, for example, of course, these studies usually come from either North America or the European countries. So the prevalence figures in the European population comes around 4 to 6 cases per 100,000 population. And in the North America, for example, and the Canada, the prevalence comes to 6 to 9 cases per 100,000 population. So it's not that rare, in other words. There are distinct clinical features when it comes to ERA, for example. And again, in this whole presentation, I'll be a little bit focusing on two things. One is that how much it mirrors what we know about the adult spondyloarthritis. And again, looking at, there are very we will discuss in the end about the treatment options. But again, in this slide, what you're seeing is that these clinical features, they absolutely mirrors with a counterpart, what we call adult spondyloarthritis. For example, of course, it's more common in males. There is more enthesitis when it comes to the uveitis. The features of uveitis are very much similar to what we see in spondyloarthritis, adult spondyloarthritis. For example, acute anterior uveitis, it is unilateral, alternating, so very much similar to ankylosing spondylitis patient that we see. Again, the age is very important. They come around the age in the middle adolescent age, 10 to 12 or 10 to 15 years of age. Again, when it comes to the peripheral arthritis, usually these are, the patients would have more, the weight bearing lower, for example, the legs, the knees, the ankles, and the hips, for example. Another thing which is a little different in juvenile spondyloarthritis is, although sacroiliitis is very common, but when the patient usually presents, sacroiliitis is not there, so usually it follows. In other words, the enthesitis comes earlier, and the full-blown sacroiliitis visible on X-rays or MRIs comes a little later. Interestingly, psoriatic arthritis has a bimodal age of onset when it comes to the juvenile population. For example, one subset comes very early. Again, these are the typical patients that we see, ANA positive, for example, the females. They usually present around the age of 2 to 3 years. There's a dactylitis there. Usually oligoarthritis, but usually becomes polyarthritis not that long afterwards. Then there is a late onset of psoriatic arthritis, which again, very much similar to what we see in the adult psoriatic arthritis population with equal gender distribution. The lower, for example, the legs can be anything, of course, but it is very much similar to when it comes in the late adolescent age, very much similar to what we see in our adult psoriatic arthritis population. When it comes to the defining psoriatic arthritis or classifying psoriatic arthritis, of course, in the kids is when they have arthritis, and of course, at the same time, there is a psoriasis in that particular patient. Of course, the diagnosis is very clear, but if some kid comes with arthritis, so we look for these three things. One is, of course, if there's a family history of psoriasis, or if there is a dactylitis there, or the typical psoriatic nail changes. If two of those things are there, along with the presence of arthritis, it's easy enough to classify these patients as having psoriatic arthritis. Comorbidities are common in both ERA and psoriatic arthritis, for example, depression, IBD, and uveitis. But the main difference is the uveitis in ERA is very much similar to, as I mentioned, in what we see in ankylosing spondylitis patient. But the uveitis, when it comes to psoriatic arthritis, is a little different. These are the patients usually would have more chronic form of uveitis, more aggressive form of uveitis. There could be a lot of them having pan-uveitis or even posterior uveitis rather than the acute anterior uveitis that we see in ankylosing spondylitis or ERA. When it comes to the genetic, for example, the background of these patients, again, this is very much similar when we look at the ERA patients. It's very much similar to our ankylosing spondylitis or adult spondyloarthritis patient. For example, 50% to 90% of these patients with ERA are going to be HLA-B27 positive. Not only this, but also the polymorphism in ERAP1 and IL-12A, for example, which is very well known in adult population, they are also been shown to be positive in our young kids. So again, talking about the same concept, that this is not just a juvenile age, this is again similar to what we see, the same disease what we see in our adult population. When it comes to the genetic association, for example, in the psoriatic arthritis, the HLA, for example, the class 1 is very well known in the adult population of psoriatic arthritis to be directly associated with the psoriatic arthritis. Rather, it has been told that the HLA class 1 links with the seronegative and spondyloarthritis population, and the class 2, for example, is usually linked with the rheumatoid arthritis. So class 1 is very much similar to what we see in psoriatic arthritis. For example, if somebody with the psoriatic arthritis is HLA-B27 positive, they're going to have much more severe and aggressive peripheral arthritis along with axial arthritis, and they're going to have a less severe skin disease. If somebody is going to have HLA-C0602, for example, they're going to have a much more severe skin disease and much milder peripheral form of arthritis. HLA class 2 association have been shown little different to what we see in the adult population, that they are also associated in this particular subtype of juvenile arthritis. When we talk of the burden of disease, usually these patients, naturally they experience the delay to diagnosis, but not that much that we see in our adult population. Usually it has been shown in studies, the ERA patients would wait, again in the European population, they wait for at least 6-8 months before they get diagnosed. In psoriatic arthritis, it does take about a year before they get diagnosed. So again, not that much different, but again, a lot less what we see in adult population. When it comes to patient-reported outcome measures, it is well known that when we look at the ERA and psoriatic arthritis, for example, these patients experience much worse form of pain and also worse health-related quality of life compared to their other subtypes of juvenile idiopathic arthritis. So it means these patients would have much severe form of disease affecting their quality of life. Again, the studies have clearly shown the risk factors associated with the worst outcome. For example, the patients belonging to lower socioeconomic populations, patients who already have sacroiliitis on their first visit to a rheumatologist, and the patient who have got ongoing enthesitis. These three have been shown in multiple studies are associated with the worst outcome. For example, if you look at our population, the low socioeconomic countries, for example, so what you're seeing here is that 28% of the patient, for example, of ERA belonging to the low socioeconomic group would have joint damage compared to only 12% of the patient living in the high-income countries of being having affected by the joint damage. This is a very important slide. This has literally changed the concept. I want you to just have a little bit of a look into this slide. So this is one of the first studies, again, the follow-up study, more than 500 patients followed up, and after 18 years of the disease onset, after 18 years of symptom onset. So what you're seeing here is that 23% of the psoriatic arthritis patients and 14% of ERA patients would have articular damage done after 18 years of symptom onset. And if you look the other way around, the functional limitations, as per the HAQ score, for example, 39% and 36% of these patients are going to have functional limitation of the day-to-day activities. But the worst of all is, after 18 years of symptom onset, 65% of the ERA and more than 50% of the psoriatic arthritis patients are going to have ongoing joint disease, ongoing active arthritis, synovitis, or enthesitis. It means that this particular disease, that old concept that the juvenile or idiopathic arthritis is going to be only there for a few years. You know, we all, at least I was told the same way, that when they're going to enter into the adult age, for example, most of them are going to be fine. They will not require long-term, for example, the immunosuppressions. But this disease, this particular study has changed that concept, that after 18 years, 65% of these patients are going to have ongoing active disease. So let's look at what have we got, for example, in our hands to offer to these young kids. So these are the little bit of the snapshot of available options. So this is very much similar to what we give to our adult population. We start with naturally with NSAIDs, short-term glucocorticoids, and of course conventional synthetic DMARDs, which we usually use for peripheral arthritis, not for axial disease, not for enthesitis, and of course we have the biologic DMARDs. Comes to anti-TNF, we have it for a long time, but in last at least a month or 2 months, we have now the availability of secukinumab, which is now licensed by FDA for treating juvenile spondyloarthritis. So this is the latest, for example, the recommendations from the ACR and the Arthritis Foundation. I'm not going to bore you with all this. So it is, if my rheumatology colleagues can appreciate, this is very much similar to what we see in our adult population. This is one of the landmark studies published very recently looking at the secukinumab, for example. We know about the anti-TNF, which have been licensed for juvenile psoriatic arthritis, juvenile idiopathic arthritis for a long period of time. But this is the study which has been the basis for FDA approval of secukinumab. In summary, what it shown was that 53% of enthesitis-related arthritis have a reduction in the risk flare after 2 years of treatment with the secukinumab, and 85% there was a reduction, 85% reduction in the risk of flare of psoriatic arthritis with the secukinumab. And very recently we know that Cosentyx has also been approved, at least in European population, as a first-line systemic treatment to treat skin psoriasis. So we know this, it goes without saying that the earlier we treat these patients, of course, there is a much better long-term outcome, and this has been reflected in the formal guidelines by the ACR and also Arthritis Foundation, that early initiation of the DMARDs, that should be important, and that should be the basis. The moment we diagnose with patients with a JIA, we should be treating these patients as soon as possible. And the one slide I've shown there, so for us, for the rheumatologists, so the gold standard of any management success is that we can not only take the patients into remission, but we can achieve remission of drugs. That without drugs, the patient has achieved remission, and that is the gold standard, for example. So this particular study has shown, again, it's 10 years of follow-up data of more than 700 patients of JIA. What it has shown is that if we introduce biologic drugs within 2 years of symptom onset, 20% of these patients would achieve remission of drugs. But if there is a delay of introducing biologics from 2 to 5 years, this particular success is halved, right? So only 10% of these patients eventually will achieve remission of drugs. And then, again, if there is a delay of introduction of biologic of more than 5 years, only 5% of these kids would ever be able to come off drugs. So this is phenomenal. And again, emphasizing the whole need that we should be treating these kids, not just early, but rather with effective treatments. And we know that, of course, the biologics are predominantly used in the North America and the European population. But again, there's a lot of differences there. For example, if you look at the GIA population, more than, for example, 50%, around 50% of the patients in North America are on biologics, these kids. But in the European population, there are only one-third, around less than one-third rather of these patients are on biologics. And in UK population, it's that, for example, a young kid attending any pediatric rheumatologist, it takes more than a year before they go on any particular biologic. So there's a lot of delays there, naturally. And of course, we can discuss like what's happening in our country. This is, again, very important slide. And what it's simply saying, again, the same concept what I mentioned earlier, the longer we delay introducing these patients, the longer there's a delay even in introducing biologic, there is, of course, a worse outcome. But even though the patient who are on biologics, for example, in this particular study showed, even though the patient on biologics, I'm talking about the biologics anti-TNF, for example, the 65% of the ERA and 54% of the psoriatic arthritis patient would have ongoing active disease in spite of being on DMARD, and the majority of those patients, although they were on as well, I'm talking about the anti-TNF, not the secukinumab. We do not have the data of secukinumab. I hope that might be a little different compared to what we know in anti-TNF. For example, another study, 14 years, that's another third study now. It's the 14 years follow-up data. 14 years follow-up data of GIA patient. And what it has shown is that only 27% of the ERA and only 11% of the psoriatic arthritis patients were able to achieve complete clinical remission. So it means that 80 to 90% of our young kids, although they have been on some treatments, but they still have got some ongoing active disease. I'm just going to share a very recent case, which I've seen after I was allocated this particular talk. So this was a 13-year-old girl from Salford. Literally, she walked into my office. Literally, her parents were holding her in their arms. So she walked in, they put her in the chair, in the couch there. And what was very clear was that she has got very active disease. She has got So this particular girl has got quite active disease, has been ongoing symptoms of the lower back pain, leg pain, was not able to walk around. She was off school for the last number of months. As I mentioned, she was literally, the parents carried her in their arms when she walked in her office. So she was having active disease, as I mentioned. She was being labeled as somebody having probably infection or something. She had already been told by orthopedic colleagues that she needs a surgery in her hip, and I was unclear what would be the reason. So these are her MRI. I'm sorry, I should have taken what you're clearly seeing here is, for our fellows here, is that she has got bilateral trochanter bursitis, she has got bilateral active hip involvement, bilateral hip synovitis, what you're seeing, and also on the left-hand side, what you're seeing is intense uptake in the left sacroiliac joint, intense uptake in the left sacroiliac joint. So clearly, very obvious from the very first reading that she has got very aggressive spondyloarthritis. And these are again the different images of the same one, right? So she was seen on the 10th of the January. So again, she was started on the NSAID, the usual things, and of course the same. I think the following day she was given biologic. She was started on the secukinumab. I ended up giving her a very big dose of secukinumab, and again she went home and she was seen last week. And this time when she walked in, I was absolutely amazed. Rather the surprise or the response what I received from this lady was a little bit more than I was expecting. She came to me within a month's time, 100% asymptomatic. She had started going to school within literally 2 weeks of being pain-free, and she was able to run around and do her daily chores. And it was absolutely priceless that within a month, this much transformation, that a month ago the parents would come